Welcome everyone, and thank you for joining this Brain Inflammation Collaborative webinar today. I'm Christy Jagfeld, one of the co-founders of BIC. I've been a patient advocate since 2012 when my daughter was first diagnosed with POTS, EDS, mast cell, and PANDAS, and launching Unhide has been a culmination of a lot of hard work and time as we work to find more collaborative ways to research. My daughter was part of a research study starting in 2014 that was life-changing for our family, and I wanted to bring that to other families. But I'm super excited for today's webinar as we have a very special guest speaker. Dr. Leonard Jason is renowned for his research on ME/CFS, someone that patients and advocates look for his extensive expertise. As a person with ME/CFS himself, he's also uniquely qualified to discuss living with an energy-limiting illness and the importance of pacing as an interventional practice. The Brain Inflammation Collaborative's Anvita Gouda will tell you about a post-exertional malaise questionnaire or PEM questionnaire on Unhide, our free online health platform, and that is powered by patient data. And so I'd like to formally introduce you to our guest speakers today, Dr. Leonard Jason and Anvita Gouda. We'll first hear from Dr. Leonard Jason, one of the most respected and prolific researchers of ME/CFS. Dr. Jason developed ME/CFS after contracting mono in 1989. He received a BA in psychology from Brandeis University and a PhD in psychology from the University of Rochester. He is a professor of psychology at DePaul University and director of the Center for Community Research at DePaul, which includes the DePaul University Chronic Fatigue Syndrome Project. His pioneering ME/CFS research is focused on the epidemiology and prevalence of the illness and on the impact of using various case definitions for diagnosis and research. Dr. Jason has served on review committees for the NIH, and he is a former president of the Division of Community Psychology of the American Psychological Association. Next will be Anvita Gouda, one of the Brain Inflammation Collaborative's clinical research associates. Anvita is a 2025 graduate of the University of Cambridge, where she received her Master of Philosophy in Cognitive Neurosciences and holds a bachelor's degree in linguistics and chemistry from New York University. In light of her background working with MS and stroke aphasia patients, she is passionate about health accessibility and is committed to making treatment and rehabilitation more intuitive, usable, and accessible for all patients experiencing neuropsychiatric symptoms. Thank you so much for joining us today, Dr. Leonard Jason and Anvita. I'll hand it over now to Dr. Jason.
Thank you so much, Christy. Thank you so much, Brain Inflammation Collaborative. This is really an honor to basically be part of this. Lydia Schwartz and Maya Patel will also be presenting. Next slide. So we began doing work in the early to mid 1990s, and we first sent out a survey to about 1,000 patients, find out what it is that they were interested in terms of treatments. And what we found was self-help, social services, general advocacy. Those were what was most important. Certainly, it was not what was being provided at the time. Next slide. So in the early 1990s, there was a person named Furculin who basically offered what's called CBT, or cognitive behavior therapy. What this model suggested was that patients with ME/CFS attribute their symptoms to physical causes, are preoccupied with physical limitations, do not maintain regular activity, maintain a self-defeating preoccupation with symptoms. Next slide. When we looked at this, we said this was the model that they were basically testing out. They didn't have data, it was just a theory, but they didn't test this particular model, which we then decided to test out in the real world. Next slide. So for the next few years, two of my students, basically Song and another student we'll talk about, looked at several different aspects with a patient group. Very statistically validated way of seeing, does the model work? Next slide. And Madison Sunquest and Sharon Song basically replicated the same results. Basically, the cognitive behavior theory that presumed that individual symptoms stem from deconditioning and maladaptive illness beliefs was just not validated. And if the patient had a more stringent case definition, it didn't work at all. So the equations did not support it, and we said to ourselves, that's really what the patients were saying at the time. Next slide. This is confirmed in a study done in Norway, where 79% of participants with experience with graded exercise, which would be supported by this cognitive behavior therapy model, actually they said it worsened their health status. And pacing was evaluated by 96% of the patients. 96% said that's the thing that's helpful. Next slide. So in the early 1990s, we began doing research, and we did a series of studies that looked at what happens when patients with ME/CFS pace. And I might add that for myself, after I did get mono and had to leave DePaul for over a year, and was actually in a situation where for times I could only be on the phone for about 5 minutes a day. I walked outside for a couple minutes. I'd spend the rest of the day basically not feeling well, incapacitated. So I had a pretty severe case. And I knew that this cognitive behavior therapy model, which was being promoted at the time, did not make sense for me or for the other patients that were being affected with this illness. I was fine before I got this virus, and after it, I was in a very difficult situation. Next slide. So it happened in 1993. Myself and several people, including Harriet Melrose, who was a patient within the Chicago area, we began talking about the energy envelope. And what we found was that, in a sense, if you could figure out how to stay within this energy envelope, you'd actually be able to at least not get worse and maybe even get better. And I found for myself that actually for a period of time when I began to do less and actually trying to stay within my own energy envelope, which I'll talk about, I began to actually improve. And I figured at the time maybe I'd never get back to I'd been pre-morbid, but that was something I could accept. When you have basically 10% of your energy that you once had, if you can get it up to 40 or 50%, you can do actually quite a lot with that. So that's what I was saying. We're not curing the patients, or I didn't think I'd ever cure myself, but I thought I'd be able to cope better with this illness using this particular method. Next slide. So the energy envelope recommends that patients pace their activities according to their available energy. And Ellen Goodsmith was in England, and at the same time was developing her ideas on pacing. And we became good collaborators over time. And what we basically believed was that symptoms worsen when the body and brain are pressured to function beyond their current capabilities. So the objective is stay within the energy boundaries, however one could do that. Next slide. This is one way of looking at it. If you see on the left, you see an ME/CFS battery. That's a person with ME/CFS. Say they have maybe 20% of what they once had. 100% is what they once had. The healthy battery is basically closer to 100. So if you've got about 20% of your battery, the biggest problem you're faced with is that you've got demands for using actually more than that battery. Next slide. So if you have a perceived energy, say of 40, and your expended energy is around 40, then you're in balance with your perceived and expended energy, and you're staying within that energy envelope, or you're probably pacing. Next slide. This is what often happens. If you have 25% of your perceived available energy, but you're doing twice as much, expending it, And this is what I found myself doing, just trying to do basic things of kind of keeping the house cleaning, getting food. Basically, that threw me off constantly. It's kind of like a yo-yo effect. I'd basically store up some energy and then do too much. It wasn't working for me. So I had to do something different. And what I learned to do was stay within this energy envelope. Next slide. So this is just, again, sort of staying within the perceived and expended energy. And if you basically are able to stay somewhat within that energy, you can basically do better. And it doesn't mean that sometimes you're going to go way over. That's okay. You just then take it easy to sort of kind of recoup that following doing too much exertion. Next slide. So we began doing some studies to test out this theory, and using electronic actigraphy, we had patients basically chart their energy expended, physical exertion, mental exertion. We found they were all positively related to actigraphy. In other words, the measurement. We also found that positive significant relationships between current fatigue level and amount of energy that participants perceived they had used over several days. So this was confirmations. We were working with Warren Tryon of Fordham University, who's an actigraphy expert. So it wasn't just our beliefs or our self-perceptions, it was actually behavior, activity, amount of activity that was being validated. Next slide. We did several additional studies where there was a correlation between those who experienced a range of negative symptoms and disability when they extended beyond their energy envelope. Again, correlation, not causation, but it was convincing to us that it's worth us looking at this more closely. And then patients with ME/CFS can rate their weekly level of available and expended energy. We had good inter-rater reliability. So from a science point of view, that's important to validate. Next slide. Our first case study was done basically in March of 1996, and we had a person rate their fatigue, which was about 35% on a 100-point scale. Their expended energy was 39. Their perceived energy was 24. So you can see they were outside their energy envelope. By June of 1996, they basically were able to expend 55. Their perceived was 49. So they're a little bit more pacing, staying within the energy envelope, and their fatigue level is decreasing. Doesn't mean they're cured. They're just being able to cope with this illness better by not having overexertion going on. Next slide. This is an example of a person keeping track of their perceived and expended energy. The red is their expended energy. This is very much like I was. I was basically doing too much. My perceived energy was just too low. But you can see when these things start matching here, that means you're starting to learn how to stay within the energy envelope. Next slide. This is another example. Over time, when a person was able to learn how to stay within their energy envelope, their fatigue ratings doesn't mean they were zero, but they were lower. So that's the idea. If you can keep the fatigue low, your actually energy rate is going to get bigger. And that doesn't mean you're healthy, doesn't mean you've recovered. It just means you've improved. You've got a little bit more functioning. Your battery is not being drained constantly. It's starting to basically gain a little bit more energy. Next slide. Our second case study was a 46-year-old female with ME/CFS. Her perceived energy was less than 10. Her expended energy was about 25. So she was constantly doing more than she could. What was very interesting, she went to visit a relative where perceived and expended energy more close in the envelope, and the fatigue ratings. So it doesn't mean she was cured. She went from 95 to 75, and she realized the importance of social support. This was another clue that if we can provide resources for people so that they don't have to be pushing themselves so far beyond their perceived energy, this might be something very therapeutic. Next slide. So an individual with ME/CFS benefited from social support and personal assistance from a trained undergraduate from DePaul. And this was helping the person stay with the energy envelope. The buddy got 1 hour per week. We had 12 individuals with ME/CFS. Half received the buddy for 4 months, and the other half were controls. Next slide. we had significant reductions in fatigue severity reported for those receiving the buddy. So if you had a buddy and you can basically not have to do as much, the buddy could help you clean, shop, do other types of things. That means you can basically have a little bit more close match between perceived and available energy. Next slide. This is a fourth study that we did in 2000, where we basically had several patients, three, who basically had their baseline perceived energy of 65, expended energy of 76, and actually a high level of fatigue. When they started learning how to pace so that their perceived and expended energy were closer, we noticed some nice reductions to fatigue. Doesn't mean that they were cured, just means that they had less fatigue, able to cope a little bit better with this illness. Next slide. This study was involving an empowerment program where we got funding from the federal government to have what's called an illness management program, and it was group case consultation. We gave free transportation and services to the patients. Next slide. 50 individuals were assigned to two groups. One group got the intervention, second group served as controls. The second year, the controls then got the intervention. So everybody got an intervention over time. Next slide. This was our intervention. It was a 4-month group intervention. Hour 1 was devoted to goal setting. Members reported on behaviorally focused objectives and goals. Hour 2 focused on talking about energy theory, cognitive coping, personal relationships, self-relaxation coping, economic self-sufficiency, nutritional, and employment issues. Next slide. Next 7 months, case coordinators, 2 people who recovered from ME/CFS, assisted each participant with appropriate supportive services, individualized self-advocacy, assertiveness training and skills, and some financial support to create linkages to community-based services. Next slide. And you can see the patients who were given program significantly increased over time with their overall quality of life, and the controls stayed about the same. Next slide. And symptom severity of those who provided the participants with the program significantly decreased their symptoms, where the controls stayed about the same. The program people were the ones that are in blue. Next slide. The next intervention was we had weekly visits by student paraprofessionals. They helped with tasks needed to be done in an effort to reduce taxing demands and responsibilities that participants regularly encounter. This model of rehabilitation focused on avoiding overexertion in persons with ME/CFS. It aimed to avoid setbacks and relapses while increasing their tolerance for activity. Next slide. So participants were randomly assigned to either a 4-month buddy intervention or a control. Those that received the student buddy intervention had significantly greater reductions in fatigue severity and increases in vitality. So if you have a buddy, if you have someone who can help you, assist you, what an important intervention, because then you don't have to be exhausted all the time trying to do the basic things of life. You're able to really focus a little bit on more your illness. Next slide. And here you can see basically the group with fatigue severity. It's hard to see this, but the line that's going down, straight down, means their fatigue severity from test point 1 to test point 2 significantly decreased, with the controls that did not get it stayed about the same or increased a little bit. So that's, again, reaffirming the data on this. Doesn't mean they're cured, means that they're functioning better, less fatigue. Next slide. And vitality. Their vitality, in this particular, this is the group that got the program, increased, whereas those who didn't get the program decreased. This was a significant interaction effect. Next slide. So we then had 100 patients with ME/CFS were provided biweekly meetings with trained nurse therapists for 13 sessions. We had a baseline, post 6 and 12-month follow-ups. Next slide. And 2 groups of patients were identified. Those who were able to learn how to basically stay within the energy envelope and those who were not able to. So we kind of said, does learning how to stay with the energy envelope make a difference? Next slide. This is just the equation that we used. Next slide. And you can see those who stayed within their energy envelope over time, this is their physical functioning, actually increased. Those who did not learn how to stay within their energy envelope did not. So again, showing that staying within the energy envelope did make a difference on physical functioning. Next slide. And this is basically fatigue severity. Those who basically stayed within their energy envelope in the pink line significantly decreased fatigue severity. Those who did not able to stay within the energy envelope stayed about the same. Next slide. So in summary, we've got significant support for this energy envelope. Healthcare professionals that treat patients with ME/CFS might incorporate strategies that help patients self-monitor, self-regulate energy expenditures. We believe in pacing and staying with the energy envelope. If you look at patient surveys with long COVID, also with ME/CFS, multiple studies over time, when you ask patients, what is it that's been most helpful to them? They often say pacing, which doesn't mean basically pushing yourself beyond and having the way that so much has often been talked about with the types of cognitive behavior therapy programs that patients generally have not found useful. Next slide. Pacing is now widely used strategy for managing PEM, post-exertional malaise, and ME/CFS, and related post-viral conditions such as long COVID. And consensus guidance identifies pacing as a core self-management strategy for reducing PEM risk and stabilizing function. Next slide. A systematic review and meta-analysis found that pacing interventions over time are associated with improvements in physical function and pain. So not just our laboratory, where we started doing this work in early 1990s, but there are basically consistent findings on this issue across research laboratories. Next slide. Digital pacing has been operationalized through mobile, wearable, enabled platforms. That's called digital pacing now. Next slide. And studies demonstrate this feasibility of delivering adaptive pacing using real-time activity tracking and just-in-time feedback. Qualitative research indicates that individuals with post-viral conditions value these tools for enhancing autonomy, symptom awareness, and control over daily activity. Next slide. So SolveME founded the UME platform designed to study ME/CFS and long COVID. Their registry had data that had over 4,200 participants, and it had broad geographic reach in all 50 states, international participation. Next slide. Their registry integrated a symptom tracking app with longitudinal surveys. The app engagement indicated that remote symptom tracking is feasible, and they had over 38,000 cumulative tracking days in this one study that they published by Ron Miller and others, 2022. Next slide. The registry enrolled a substantial proportion of severely ill house or bed-bound participants who are typically underrepresented in clinic-based studies. Next slide. So we do think that this is a very valuable contribution to the literature that the organization SolveME has made, and there is widespread use of these types of apps and platforms that we're going to be talking a little bit more about. Next slide. And I'm going to now turn things over to two of my associates. Lydia, Maya, why don't you take over?
Great. Thank you so much, Dr. Jason. Expanding on your points, these positive user experiences with the You and Me platform then paved the way for the development of a new interface. Brain Inflammation Collaborative's Unhide platform and SolveMe joined forces to create the Unhide Solve Together unified platform. About 1,000 You and Me participants have enrolled in Solve Together Unhide, further reinforcing these positive experiences users have had with the platforms. Next slide.
So this created the Unhide Solve Together unified platform. It's a digital health platform that helps patients and caregivers track symptoms, identify patterns, and visualize their symptom data over time. It's used for ME/CFS, long COVID, and other infection-associated chronic illnesses. It's accessed online or through an app called My Data Helps, and the app connects to a range of wearables, for example, Fitbit, Garmin, Aura, Apple Watch, etc. Next slide.
There are currently about 1,890 users connected to the app using wearables, with a large portion of participants using Apple Health. This wearable data is then used for pacing. Next slide.
The Unhide app features include daily symptom logging, tracking treatments and activities, wearable syncing, generating reports for clinicians, and pacing notifications. Next slide.
These pacing notifications give us an idea of how much we are exerting ourselves throughout the day. The notifications from the app will help you establish personalized baselines and limits, essentially the maximum amount of activity they can do without causing symptoms to worsen. The three pacing components are step count, calories burned, and heart rate. Next slide.
So here's an example of one of the notifications. This is for step count. So you're notified when daily steps are near or above your recent averages. And a sudden increase in activity, which can be measured through step count, could be associated with symptoms worsening. This is an example of a notification that will pop up on your phone to let you know about your pacing regarding your steps. Next slide.
For calories burned, you're notified when calories burned are near or above your recent average. You might receive a notification similar to the one pictured on the slide. When calories burned is unexpectedly high, this could indicate a high-risk day for a crash. Next slide.
And last but not least, this is an example of a pacing notification for your heart rate. You're notified when your recent heart rate is above a user-specified level or your average maximum. And ME/CFS patients typically show a reduced anaerobic threshold, so staying below this threshold could help prevent symptom exacerbation. Next slide.
In order to estimate and interpret your limits, users should understand and stay within their own energy limits. The app helps you stop activity before you exert yourself, which could prevent the delayed onset of PEM and crashes. Next slide.
It's important to know your specific PEM triggers. For example, walking up the stairs, multitasking, or maybe a strong odor. These are just examples of various PEM triggers, but it really differs based on the person and their specific symptoms and triggers. Next slide.
And lastly, users can translate these notifications into meaningful action. The overall goal is to help users create a healthier balance between activity and rest in order to better manage symptoms and avoid overexertion. And now we will hand it off to Anvita.
All right. Thank you so very much, Lydia, Maya, and Dr. Jason. And thank you all for being here today. I'll give you a bit of an overview about what my section of the webinar will be like. I'm just going to do a quick overview of pacing and the notifications as well, just as Lydia and Maya showed us. I'm going to show you all how you can sign up for pacing notifications in Unhide. And then I'm going to tell you about an upcoming initiative we have to learn a little bit more about patients' pacing experiences through our app. All right, next slide, please. Okay, so just to overview pacing again with the definition on the screen, it's a strategy that patients may employ to balance moments of rest and exertion and to minimize post-exertional malaise. And we're particularly interested in pacing because PEM often involves a delayed onset of symptoms. And so individuals are not are often not able to amend their exertion behaviors ad hoc because their body won't necessarily give them the physical feedback for multiple hours afterwards, which is why pacing is especially important to mediate physical, mental, and emotional activity levels and fight unexpected overexertion that arises hours after. Next slide, please. And there was one thing that I quickly wanted to say as well. So, especially in the age of funding cuts to critical research involving PEM and neuroinflammation, we are focusing on pacing as a helpful, accessible, and free service to patients alongside biomedical advancements in the field and not instead of. And so we do want to highlight that it is imperative that research in this space continues, but pacing is something that can be auxiliary as we wait for research to catch up with us. All right, next slide, please. Okay, so as of last week, 487 people who use the Unhide platform have pacing notifications enabled. And just as Lydia and Maya showed us earlier, users can employ 3 different kinds of notifications. One for your daily steps, one for your heart rate, and one for your calories burned or the energy you've expended for the day. Notably, only daily steps and heart rate are available for Apple Health users, which seem to make up the primary users of Wearable, around 1,009 participants. And another thing that I do want to mention is we recognize that emotional exertion and mental exertion are often triggers of PEM as well. But because of our emphasis on wearables as working with Unhide, we're going to focus on physical exertion as a trigger of PEM for the purposes of our pacing notifications and this webinar. Okay, so just to quickly overview the exact notifications that Lydia and Maya showed us earlier. So the way that notifications are sent to you is either as a push notification through the app, almost like a notification you get for any other app, or as a text to the number that you delineate is associated with your Unhide account. And so the way that steps are presented is there's a little emoji and you're told that you've walked X percentage of your recent average steps. And the intervals that you're presented with are 50% of your average steps, 75%, 100%, and 125%. So it covers a full range such that you're ideally able to, still have some time to make changes to how you choose to exert yourself via your steps that day. Next slide, please. Similar with heart rate, though the way that heart rate notifications show up is not as a percentage or out of a threshold. And so this maybe more so requires participants to understand where their own heart rate thresholds exist or what the average threshold for them usually is for heart rate. And next slide, please. And here we've only got I only have calories, like the calorie notification within the Fitbit notification box. But those same intervals that existed for daily steps will also be the intervals that pacing notifications for calories burned are presented in. So it'll be 50, 75, 100%, and 125% of the average calories that your Fitbit knows you to be burning over a set amount of time. Next slide, please. Okay. And so now I'm gonna talk you guys through a few steps that you can employ to sign up for Unhide pacing notifications. And notably, this will be through the app on your phone, the My Data Helps app. Okay, next slide, please. All right, so I attached a few screenshots of my own phone here. So when you click on the app, this is the homepage that you see. And the red arrow is pointing towards the bottom right corner that says More. So you can go ahead and click on that. And then next slide, perfect. You enter the More section, and right at the top is pacing notifications. So you can click on that. And so this is the screen that you see, and there's a few words on here. And notably, I'm connected to Apple Health in Unhide, but I do not have a Fitbit. So this screen that you see right here is for Apple Health users that don't have the Fitbit wearable connected. So there will be a box that allows you to connect or to turn on notifications for steps or heart rate. Next slide, please. All right, and so once you've turned on those two notification types, this is where you see. So you are notified above this threshold. So you essentially, I mean, based off of your own understanding of your limits, if you've spoken to a clinician about it, you can choose what threshold you would like for your beats per minute to be notified after. And the screen towards the right is what the pacing notifications page looks like when you do have a Fitbit connected. So as you can see, there's now a third calories burned tab, and you can turn on notifications for that too. And this last page just shows you how you can turn on notifications for the two types that are administered. So if you would prefer that you get like push notifications to your phone as you would for, say, an email or a text, um, you can select the button at the bottom that's already blue. But if you would prefer that you only get text messages to your phone regarding the pacing notifications, then you will receive an SMS message to the number that your account is associated with. All right, and so now brings me to the last part of what I wanted to speak about. So we do have data from participants who tell us that the pacing notifications are beneficial for them. But we lack some more specific data and feedback exploring what aspects of the notifications participants find most beneficial and whether there are any parts of it that they'd like to change. And I just want to reiterate that we're especially interested in feedback from participants because this is a free of charge resource that we're providing for our participants. And if there's any way that we're able to optimize it so that the most people can have access to this service that they find really helpful, that is our goal. All right, so next slide, please. Okay, so we at BIC are currently developing a PEM pacing questionnaire. And so this questionnaire is not going to be more than 10-ish minutes long. And the gist of it is going to be a few questions that asks you, a user of pacing notifications in Unhide, how you feel about it. And next slide, please. And so some of the things that we'll be asking about in this survey are whether you actually look at your notifications, whether at some point you used to look at them a bunch, but now you find them unhelpful or too frequent, whether you think that the pace of notifications actually allows you to make changes to your day. And as I was saying earlier, with steps and calories, whether those intervals of 50, 75, 100, and 125% of steps or calories expended are actually reflective of how you feel internally. And also whether these notifications have any sort of unintended adverse effects for you as a user, such as inducing feelings of guilt for not slowing down when you know you need to, for increasing your anxiety levels, for inducing rumination about your behaviors, and most importantly, whether these notifications really help users effectively prevent their PEM episodes. And we truly are interested in anyone who has pacing notifications enabled feedback. And so if you decide to enable these notifications right after this webinar, we are still interested in your feedback, even if you haven't used it for months by the time you see this questionnaire. Even if you're someone who used to have the notifications enabled but no longer does, for whatever reason, we'd like to hear about why that is as well. All right, next slide. And for those of you who are not yet a part of Unhide, you can scan this URL now to join our platform, either as an app on your phone or through a web browser. All right, thank you everyone, and we are ready to take some questions now.
Great. Thank you, Dr. Leonard Jason, and Lydia, Maya, and Anvita for this presentation. It's really important to keep pushing this work forward, sharing experiences, and highlighting the opportunities for research. And really, we just want to help patients. And so it's really important to get your feedback. And, we do want to make sure that patients are finding our platform useful. So I'm going to ask a couple of questions. Let's see here. Uh, this first question is for Dr. Jason. Um, what is your advice for the neurocognitive subset of ME/CFS patients who suspect neuroinflammation and actionable steps they can take? And I'm not sure. I think that this is a question, obviously we focused a lot on pacing, but people are also always wondering if there are other additional things that they can be doing.
Well, based on some of the best evidence with both long COVID and ME/CFS, basically, we do think that there's some neuroinflammation, and there's a number of studies that suggest that. Now, I won't get into all the biology. My lab in Chicago with Dr. Ben Katz and people who are doing work with Epstein-Barr virus at Rosalind Franklin, as well as people at Northwestern who are doing both genetics work as well as others. We're basically looking particularly at what happens with something called an enzyme that basically elevates what's called KP. And we do think that that is connected with all types of metabolites disturbances that occur. So the key question becomes, how does one reduce some of that neuroinflammation? And there's a number of clinical trials that are going on around the country and the world that are trying to sort of find out if there's ways of reducing that inflammatory process that's causing a lot of these problems. So certainly, if you think about it in a simplistic way, Th1 and Th2, which should be in balance. So these are the pro-inflammatory and anti-inflammatory cytokines. What we want to basically see is, can we basically get them back in balance? And a number of laboratories have found that, and our group has found, for example, the Th2, which is supposed to shut down the inflammatory system after you've kind of worked on a virus or bacteria, generally that system tends to be impaired. So how do we get that Th1, Th2 system back in homeostasis? There's a tremendous amount of work that's going on around the country. Our group is looking at it as well. And we think that, hopefully that there will be these new ways that, potentially can reduce that neuroinflammation. So that's just a kind of a snapshot, but it's a great question. And really, it's a lot of work that's going on in that area.
Yeah, that's very helpful. I guess in this one maybe kind of piggybacks off of that, and maybe you don't have a direct answer for this, but what future therapies are you most excited about that address neuroinflammation specifically in the ME/CFS population, or is it more of your general answer that unless you have some specific ones?
So I certainly know that there are some important clinical trials going on, and there is some good data that is coming out that, again, suggests that things that basically allow that neuroinflammation to get reduced seems to be probably the key. And there are several ways to do that. But I do want to suggest, and this is why we really focus on the pacing so much, that if your body in some ways is basically pushing itself and you're constantly, in a sense, trying to get the demands done, ultimately what that's going to have is an effect on the body and the brain. So what you want to really do is try not to kind of constantly push yourself beyond your energy limits. And that's what happens frequently. What we find is that people come to us and basically sometimes they're just used to, the Protestant work ethic, work your way through it, which is kind of a lot of the strategies that a lot of mental health professionals continue to push, saying just work out a couple times a week and you'll feel okay. Well, maybe if you have a major depressive disorder, you're going to basically feel better by doing some aerobic exercise, but that's not going to be helpful. And what happens is, to the extent that the person is on overload and more overload and overload, ultimately, this is going to have really effects. So we don't want the person to experience PEM. We want to reduce those episodes, and we want basically the person to try to find that homeostasis. And how does one do that? One does that by having a support system. The environment is so important. People can't do it alone. They have to do it with an environment and supports and people that are helping them. That's the healthcare community, families, friends, and work associates as well.
That's a great answer. And I think oftentimes that's a big area of struggle. Not everybody has all of those great support systems in place, or they don't have family members that always are supportive or understanding. And there's a lot of people that still don't believe. And, so we have a lot of work in as far as awareness and education. And I love your project with the buddy system and how well that seemed to work. You can't do it alone. And you think about a single parent, and has kids and doesn't have a buddy to help them, but they have to get through their day. So I think that obviously healthcare in the US, we have a long ways to go in fixing a lot of that. So here's a question for Anvita. Um, Please clarify, are two apps being used, Unhide app and My Data Helps? If not, please say again what My Data Helps is.
Absolutely. That is a very good question, given that we have many names for things. My Data Helps is the baseline app that hosts many different kinds of studies, Unhide being one of them. So when you download the My Data Helps app, you can use Unhide through that. In theory, you could be part of other studies through My Data Helps, but they essentially allow us to host our platform and give it all the functionality that it needs to work quickly and well for you.
That's a great answer. And, kind of going back to Dr. Jason talked about You Plus Me, that is a sort of the beginnings of where it evolved into Unhide, just to kind of keep that separate too. Um, and here's another question, probably for Dr. Jason. How valid are wearables for persons who are virtually completely bedbound but can overexert with brain activity and talking? I know that Anvita talked a little bit about how we focus on the physical part of it. So I don't know if there's any kind of tips for people that have more of, they are bedbound and the brain activity and talking piece of it. How does that kind of play into the digital space?
So it's an individual decision. Does feedback help a person, whether they're bedbound or whether they're not bedbound? Is that something that they want? Is that something that is helpful to them? I personally think that regardless of the person's condition, learning how to pace is probably important. And basically, if one is having, for example, to get up and take a shower and get back in bed, or have breakfast and get back in bed, whatever one has to do, depending on exactly where the situation is, one still has to kind of keep an account in some ways of how much activity they're doing. So to me, pacing is really the bedrock. It's really the foundation for people trying to get kind of control of this illness. And slowly, just think about it. If you have a battery in a car and you're constantly overcharging it in overactivity, that battery is going to get weaker. But if you let the battery, in a sense, begin to regenerate and restore itself, and not put strain on it, it could potentially get a little bit stronger. So we're not saying that the battery is ever going to be 100%. What we're saying is that the battery will get stronger. So that's what we believe. That available energy, that perceived energy, will slowly increase. And basically, there's probably a biological explanation of that in terms of the inflammation beginning to reduce, the Th1, Th2 balance beginning to come back in balance. So yeah, I think that should be the bedrock for wherever one is, but particularly a person that's severely impacted and bedbound and homebound. It's just so critically important that we don't put the onus on the patient. We need to basically say, what's the support system? And taking that person and putting them into a hospital where they're going to basically have announcements and lights and people coming into the room constantly who possibly don't understand that person, it's not the solution. What they need is individuals who are caring, understanding, sensitive, and being able to understand that the patient is in a desperate situation, and we've got to do everything we can to increase their quality of life.
That's a great answer. Here's a question for Anvita, and it's in regards to the Garmin device and the compatibility. Are you able to answer that one?
Yeah, absolutely. So, unfortunately, the only wearable devices that are compatible with pacing notifications now are the Fitbit and I suppose Apple Health. Um, so this is Apple Health through either an Apple Watch or also your phone if you have an iPhone that tracks your steps. Though we have had discussions internally at BIC about how the body battery function in Garmin has been really helpful and has been reported to be super helpful for specifically individuals with ME/CFS. And so it is important to us in the future to perhaps look into creating some compatibility with Garmin and the pacing notifications. And we hope to update you guys along the way.
Great, thank you. Now, Dr. Jason, you presented a slide with physical function increased after pacing. What assessment was used? SF-36? Would it imply that people are able to do more?
Yeah, basically, physical functioning with the SF-36 is the types of instruments that we used in that study. It's a well-validated kind of measure. And I do think that, the question that, keeps coming up is, how does one measure this? And people are wondering, how do you measure kind of where you're at? I mean, these are ephemeral notions. Well, that's why having an actigraph, or having, notifications, it gives you something specific. You can look at your heart rate. You can look at how many steps you've taken. You don't even realize often kind of how much you've sort of engaged in exercise and activity. This gives you immediate feedback. If that's what you want, it could be that's not what you want. But one of the kind of points is, think about yourself. I'll just make it really simple. Take a 100-point scale, and 0 means you've got basically, in a sense, no available energy. 100, just maybe 100 as to what you were, before you got sick with ME/CFS or long COVID or whatever you have. So from 0 to 100, 100 is the best, 0 is the worst. And that's basically the energy that you have, the perceived available energy, and then think about a scale from, again, 100, 0 to 100, or your expended energy. And how much are you expended? When you are basically at 100, you're about what you were doing, when you were healthy, pre-morbid condition. So just think to yourself, 0 to 100. So if you rated yourself just simply on a 100-point scale and say your available energy is a 50 and your expended energy is 75, 80, well, that's okay. You can do that in a day. You want to go to a celebration, you want to do something special, but then you want to make sure the couple days before and a couple days after, you just really take it easy so that you basically are able to not constantly be overextending beyond that battery. That's the key. You want to break that yo-yo effect of basically being sick, being very, limited in what you're doing, feeling a little bit better after resting, and then doing everything you haven't done for the last few weeks to catch up. That's called the yo-yo effect. You're going from basically feeling better and then doing way too much. So what we're saying in some ways is that you are the best judge. You are the best person to evaluate what you can do, what you can't do. And, you are going to be the person who's going to basically learn how to pace. And whether it's with these devices that we're talking about, or whether it's not with these devices, um, we want to give the power back to you. You're in charge. And that's what way it should be. You should basically bringing together a treatment team of the best in all the different areas, whether it's nutrition, whether it's sleep, whether it's pain management, whether it's 5 or 6 different areas, and you want them to be working with you. You are in charge. You are the person who's basically manning this thing. And basically, we have very specific areas that could basically make a quality of life difference. Pacing in these wearables is one important part, potentially, of this treatment plan.
Yes, thank you. And I guess, that sort of answers the question. There's one about establishing baseline, and people just have to kind of figure out they're the best judge of their symptoms and how they're feeling. And is there anything else that you could um, add to that with somebody kind of coming up with their baseline?
So what you can do is you basically just, in a sense, you can do it in a quantitative way. But I think what you need to sort of say to yourself is, okay, what could make a difference? So if a person is working kind of full time and basically exhausted, comes home and sleeps at night in the evening, weekends, spends the entire weekend in bed, and then by Monday is ready to just get through another 5 days, you know that the person is way beyond their energy envelope. They're not pacing. They can't. So for that type person, whatever one's doing, how does one figure out a way of having a higher quality of life? Well, if your whole life is that work job, and you might need to do it to pay the bills, I understand that, but that person is going to be vulnerable, and probably in that particular situation, some real management changes, and they might have to get support from other family members. They might have to take some time off. They might have to figure out a way of changing what they're doing. And notifications from these wearables can help a person figure out that transition from one state of being completely overly and excessively exertion focused to something that's a little bit more easy and balanced, depending on what that threshold is.
Great. That's helpful. Again, sometimes challenging to do all of those things, but necessary. Um, Here's another question for Dr. Jason. If there's a database of volunteers or helpers for patients who are severe and have no one, says the doctor, oh, okay. I guess that's the question. Um,
Yeah,
and
I
that
mean,
was something I was going to ask too. Where do people turn?
so, you know, I have people call me that are basically have been, you know, they have nowhere to go. Basically they're at desperation situations. It's tragic. Just think of it. If you have cancer or you have MS, there's treatment settings to go to that are going to be helpful with resources. If you have these post-viral conditions and these brain inflammation conditions that are less well understood, there really, unfortunately, aren't the types of places that are needed. So this is a terrible shame, and it needs to change. There needs to be more options for people. So what does one do? One's got to be really creative, and the most important thing is learn as much as you can. Learn what's valid and what's not valid. Become a person that can sift through information so that you can sort of say, this makes sense, this doesn't make sense. You're going to be the best judge. And basically, you're going to have to figure out a way of bringing some resources into this equation. They might not cost money. For example, there might be kind of assistance from different programs where people have volunteers to help people who have disabilities or people who are elderly or other types of folks. There might be programs within universities where there's practicum courses where basically students are hooked up with people in the community to help them. There might be nursing programs where visiting nurses might want the experience of coming into a home. There might be lots of places that are resources. So what we need to do is think out of the box. One has to think in a creative way to bring in resources that might be available. You know, it's really interesting. Another area that I work in is with substance use. And, you know, there were people who had substance use disorders and they didn't have a place to go. And they went to AA and NA groups, but that wasn't enough. They needed a supportive setting. So they got together and they formed one house. They called it Oxford House in 1975, 51 years ago. That house became self-supporting, and that house is now replicated over 4,500 houses around the country. Over 30,000 people now have a place to live with substance use disorders. What a creative solution. That is something that people with substance use disorders figured out that they could do it. Our community could also do the same.
Yeah, that's a great answer. Here is another question. Deborah, are you answering questions too? Otherwise, this could be for Dr. Jason.
Oops, sorry.
And Dr. Jason
There,
could answer this.
that's better.
Oh, there we go. So here's the question. Are you using testing objective measures of PEM? Relying on self-report leaves the door open to critics who think it is psychosomatic.
I'm sorry, could you repeat that?
Sure. Are you using testing objective measures of PEM? Relying on self-report leaves the door open to critics who think it is psychosomatic.
Yeah, that is a very, very good point. We are relying on self-report of post-exertional malaise in our platform. We do have, people who are tracking their wearables, and there is, there's some evidence that things like heart rate variability, if you're using a Fitbit, will decrease when you are in a post-exertional malaise state. We are not looking at that granular level yet. I hope that answers your question. And we do understand that there's been way too much psychologization of this illness, and we are not among those people. And we are doing our best to bring online quantitative measures that will be convincing to skeptics.
Yeah, and a lot of this patient group, it's very difficult to get to different places, and being able to participate in research from your bed or your couch or wherever you need to is, I think, super important. One of the questions here is, does the device need to be worn on your wrist? I'll just say that I wear an Aura ring, and it connects directly to Unhide as well. And if wearing something on your wrist bothers you, and I often forget that I'm even wearing, or if I'm not wearing the ring, so I find that to be a good option.
Christy, can I just mention just another quick thing about post-exertional malaise?
Yes, please.
Ultimately, we want multiple measures to understand what's going on. And that way we can validate self-reports with more objective measures. One of my former kind of students, Mark Zinn, did his dissertation, which he published using hand grip as an elicitor of post-exertional malaise. And he basically had questionnaires and quantitative EEG recordings during the entire process where he could actually chart where in the brain things were going dysfunctional when basically a person was put under a stressor using hand grip. And I might add, hand grips are a lot less difficult for a person to deal with. Now, a lot of cardiopulmonary testing is really great, but it's very expensive, and often a person has to do it for 2 consecutive days. And after that, it's not something we're against, but we just think that there's got to be multiple methods for us to understand PEM, and the more different methods. And by the way, I think the work that the Brain Inflammation Collaborative is doing in this area is really revolutionary. Just think, they're not charging anything. This is something that's being provided free to the public. That's what we should be about, providing
Yeah.
services, providing strategies, helping people, and basically doing it in ways that basically are patient-driven. That's what this is about. That's what the future of medicine is about.
Yeah, that's a really good point to bring up. We really wanted to be able to have no barriers for patients, and we want to reduce barriers for researchers. Some of that funding for the research side, reducing barriers, we need more of, but the patient side, it is all free. And I think that's something you're right, society doesn't have enough of that and options on how to help patients. One of the things that we are going to have in an upcoming webinar is these validated assessments that we talked about briefly. We're going to educate the public on these validated assessments that are used within Unhide and what they mean. And then you can get a score, and over time you can see how your score changes and things that can be done to help those scores and the correlations between the different scores. And then it can be something you discuss with your doctors. I know that sometimes that can even be challenging, as there are many doctors that just really don't have the knowledge level. And so that can be challenging too. And, hopefully something to share with a clinician. Um, Another question that's on here, and I guess I should know this, but I think I do. And Deborah, you can help me if I'm not correct. Is it possible for someone to use Unhide but keep their data private and not be used for research? So, Deborah, the answer is no. Is that correct, or Anvita? I think that it's all de-identified, and we have a data one sheet that we can send out when we send the link to this webinar. But all the data is de-identified, and it's kept safe in a HIPAA compliant database. I know that there's always concerns about those pieces, but um,
Yeah, I'd like to address that also.
yeah,
And
go ahead,
it,
Deborah.
it is in our consent form that you own your data. We will never sell your data for even a dime. That's not who we are. That's not what we're about. You can sign up to be notified if there are additional studies that you might be interested in. We're happy to send you notifications of those, but you're not going to be put into anything without your permission. Your identifying information will never be shared. But we do use de-identified data. That is part of signing up for this. And, we hope that that is a fair trade for what we hope we can offer you in exchange.
That's a great answer. Thanks, Deborah. Let's see what else there is. There's people that are asking about temperature tolerance, pain, how that all fits into the PEM piece. But I think that's all, depending on the person's individual triggers. Um,
If I may, Christy,
yes, go ahead,
I've
Anvita.
been looking at some of the questions we've received, and a few of them are about heart rate. There was an individual who asked about if they began a medication that creates heart rate fluctuations or increases their heart rate beyond their normal threshold, how can they moderate the pacing notifications so that the notifications are appropriate for this change in their heart rate. And I wanted to say that when you sign up for notifications in Unhide, you can place in there the threshold heart rate after which you would like to receive notifications. So depending on whether you begin a medication that inflates your heart rate, you can just adjust that threshold to be a bit higher based off of what you now know to be your new normal. And then if you discontinue it, you can move the threshold back down. So that can be a way to modulate getting notifications properly based off of where you're at.
That's a great answer, Anvita. Thank you. We're nearing the end of time. Does anyone see a question that they would specifically like to answer? We probably have time for one more. If not, we can close. I think that we had quite a few questions and well, I thank everybody for joining us, and Dr. Jason and Lydia and Maya and Vita. Your time that you put into this and the genuine uh, desire to have people get the help that they need and that passion. It's one of my favorite parts of doing this and meeting and talking to people. So we thank you, and we're proud to have collaborated with you. Um, if you're able, please consider donating to us. We're a 501(c)(3) nonprofit, and we're so excited about our projects we brought together with our team. And research is truly expensive. It not only goes very, very slowly, especially when you're a patient or a caregiver, but it's very expensive, and our staff time and keeping the platform and the software maintained. So if you are able to give something, we're very appreciative of that. Um, we also have some great social media, so please follow us. We have a great science writer. You'll learn a lot. I still learn a lot. And some of it he writes is pretty technical, but it's worth the read. And we do have some that's not quite as technical as well. So please join us again for our next webinar. We look forward to engaging with you soon. And thank you all for participating.